Okay, welcome back. Can everyone see me and hear me properly? Thank you, Ashwin. Okay, cool. Welcome back, everyone. Good evening. So this session will be a short one. Maybe today I have some more work and I cannot sit for a long time. Again, because sorry to say again for because of my surgery. So I'll be taking till 6:45 maybe because 7 to 7:30 I have another meeting with one pharma company. So I'll tell later on. Till this is a two-stage procedure, only one surgery is done and another one is still left. So I have to do it on 30th, which is the major one. So right now I'll be doing till 6:45. So after that I'll start taking tomorrow. Nevertheless, so this is a short session, 1.5 hour session. So that let us start with where we left already. Thank you, Hari. So let us start with it. So as we take our discussion forward with the glomerular disorders, we have some nephrotic type of glomerular disorders as well. So what are the nephrotic syndromes that we need to know? So there are three nephrotic syndromes that we need to know. One is the minimal change disease, second is FSGS, and third is membranous nephropathy, which we'll be discussing subsequently. And we have some secondary types of nephrotic disorders as well, which also will be discussed subsequently. First, let us talk about the MCD, minimal change disorder. Minimal changes is MCD. Whenever you talk about nephrotic syndrome, there are some few varieties of congenital nephrotic syndromes are there which has to be discussed. For example, as I told you, you have this capillary fenestrations which you can draw in red basically. Maybe I can make this capillary fenestrations like this. So maybe this is the capillary. And the fenestrations, we know it is 70 to 100 nanometer in diameter. And we have the basement membrane, which is definitely showed in pink right from your first year levels. There's a base membrane, we know that. And we have this foot process of the podocytes. And I think I've drawn this diagram already. I don't know whether I've drawn, but I'm sure that in the last session I should have drawn, maybe in the last month when I took the last session on nephrology. I have drawn this so that I don't want to waste much time. So, and this slit is what we refer to as a filtration slit. We know that. Maybe I can draw like this. What the hell? Okay. So this is the filtration slit basically. So we know that. So through which the molecules are going to get forced into the Bowman's capsule or the Bowman space. But nevertheless, the problem in nephrotic syndrome is very simple. You are going to have a podocyte injury. So that is why whenever you have a predominant podocyte injury, that is the foot process of the podocytes are affected, you are going to result in a nephrotic syndrome. I mean, the proteinuria will be more. Whenever you are going to have a predominant endothelial injury, endocapillary damage, typically you will result in a nephritic disorder. Typically, you will result in a nephritic disorder. Number one. Hello? நீங்க வரீங்கன்னா இப்போ கிளாஸ் ஸ்டார்ட் பண்ணிட்டேன் நான் என் ஒய்ஃப் கால் பண்றீங்களா நான் சொல்லிட்டேன் ஜிஎஸ்டி நம்பர் 33DRPK5664N1ZX ஆமா தேங்க்யூ இன்வாய்ஸ் மட்டும் எனக்கு அனுப்பிச்சிருங்க தேங்க்யூ sorry. So we have a nephritic disorder, and then we have something called as a nephrotic disorder also. This is how you are going to get a nephritic if you have predominant endocapillary damage. It doesn't mean that the disease is going to affect only the endocapillary region or a disease is going to affect only the podocytes. So they can have damages on both, but something which affects only podocytes, like we'll have predominantly proteinuria, something which affects more of an endocapillary region, it will have typically hematuria and nephritic disorder. But nevertheless, so what are the reasons for podocyte injury? There could be multiple reasons for podocyte injury. So the first reason, there are few things which you need to know about congenital nephrotic syndromes where There could be some problems in the podocyte food process. Like for example, I told you, you have nephrin and podosin injuries. For example, nephrin is a protein that is going to link the food process of the podocytes. And then you have the podosin proteins. And then you have alpha actin proteins as well. So any problem in this nephrin, podosin, or alpha actin kind of proteins will result in the development of nephrotic syndrome. Congenital problems in these proteins can result in nephrotic syndrome, which will be referred to as something called a congenital nephrotic syndrome. That's what is going to happen. And I think I've described that already in the previous session itself. And at the same time, you can have variety of other problems as well to cause nephrotic syndrome. Hyperfiltration can damage this, resulting in nephrotic syndrome. Or this basement membrane, basically, is negative charge. We know that. So the reason that the base membrane is anionic is because of the proteins, the protein constituent of the base membrane that is seen normally. And many times, albumin is something that can easily cross this endocapillary region. It's not like albumin cannot cross the endocapillary region. Albumin can cross the endocapillary region easily. So even though albumin crosses the endocapillary region easily through the fenestrations, they generally repel back and come, because albumin is also negatively charged, and our capillaries, our base membrane is also negatively charged. So because both are negatively charged, albumin, even though it enters it crosses the fenestration and goes towards the base membrane, but they don't generally go into the urinary space because they are pushed back into the endocapillary region thanks to the negative charge of both the albumin as well as the base membrane. So this is also one reason why you don't get albuminuria commonly. But whenever you lose this base membrane negative charges, you might result in albuminuria. Typical albuminuria, but you can result in other forms of proteinuria as well whenever you lose this capillary base membrane. So this is one important thing that you need to know. And apart from that, variety of other reasons can result in the development of proteinuria and nephrotic syndrome. In minimal change disease, the pathophysiology is not known, especially whenever you have a minimal change disease. It could be either a primary MCD or it could be a secondary MCD. Primary MCD typically happens in children, usually less than 10 years of age, and it's idiopathic in nature. That's what we need to know. Idiopathic children less than 10 years, typical primary MCD, don't have any cause at all. Typical clinical feature will be sudden onset edema. And the word sudden onset is very important and multiple times asked question exam. They will be having a sudden onset edema, and that will be the usual presentation. That's the only finding, in fact, most of the time, that the child will be brought to the hospital by the mother only for the sake that the child is getting swollen and edematous. Whereas in nephritic presentation, like PSGN, the child will be brought with hematuria. Suddenly the urine will be cola colored, and that's what the mother tells the doctor. But here the sudden onset edema is going to be the most important. Typically the urine proteins will be more than 3.5 grams per day. And when you evaluate these children, when you see the urinary proteinuria, that will be more than 3.5 grams per day. And MCD is one of the examples of a highly selective proteinuria. MCD is one example of a highly selective proteinuria. So what do you mean by highly selective proteinuria? Typically they lose more albumin than other proteins. So albumin is lost more compared to other proteins. So typically we find whether albumin is lost more or other proteins are also lost more by using something called as an IgG index in the urine, which is not needed right now. It's beyond the scope of the current discussion, but later on, if possible, I will tell. There is something called a urinary IgG index. Based on urinary IgG index, if it is more, then you can think about non-selective proteinuria. If it is very less, then we can think about a selective proteinuria. But MCD is one characteristic example of a very highly selective proteinuria, where predominantly albumin is the one that will be excreted in the urine. And such a high-grade proteinuria can usually come with something called a frothy urine. This is very important from exam perspective, because many times in exam, a child who is edematous coming with a frothy urine is equal to MCD unless fluid service. That's all. This why this frothy urine, that is because of proteinuria again. So a lot of proteins, they will actually produce these bubbles. So because water, when it is in innate form without any soap or without any protein, they don't generally form bubbles, even if I do whatever I want. So usually I form transient bubbles, but I don't really form bubbles. Even if I shake vigorously also, the bubbles will disappear very fast. But if you add a soap in this and then I shake it up, like you're going to form a lot of bubbles, because the surface tension will actually try to reduce the formation of bubbles. But when you lose the surface tension, you tend to form bubbles. That's the basic idea. In a patient who's having nephrotic syndrome, these proteins act like a surfactant and they prevent the surface tension from happening. That's why the bubble formation is very common. That's why in proteinuria, very common to produce a frothy urine. People with UTI, for example, any female with UTI, because there are more proteins in the urine, even they can get a frothy urine. So frothy urine is not specific, but in this setting, without any background history, no fever, no dysuria, a child coming with edema frothy urine is equal to minimal change disease unless produced. That's how the examiners wanted to ask this question. At the same time, this child may have a microscopic hematuria. It's not like they do not have a hematuria. I told you hematuria is a feature of any glomerular disorder, not only just a nephritic disorder. But around 20 to 25% of the children may have a microscopic hematuria, which is something common to see. At the same time, they might have a acute kidney injury. Many times in nephrotic syndrome, the acute kidney injury is usually due to renal congestion. That's due to edema, too much edema and too much renal congestion. So, and typically this renal congestion responds to diuretics. There will be excellent response to diuretics. So if you ask any nephrologist, just go to a nephrologist and ask, what will you do in nephrotic syndrome? And when they come with the AK, they will tell vigorous diuresis. And this is a very common thing that you see in the rounds. Whenever you go, you're a final year student or an intern or probably even a PG when you're going for rounds for the first time. In nephrotic syndrome, coming with full edema, the patient will be bloated, heavy weight, and the weight would have increased by 5-10 kilograms because of the edema. And they have a high creatinine, like 2, 3, or 4 even. So in the rounds, your professor tells the first thing, vigorously diurese them. Add as much as Lasix as possible. That's what they will tell. They typically respond to diuretics. And that is the reason. So this AK is not that bad. That is due to renal congestion rather than the glomerular damage. So it responds very nicely to diuretics. That's the most important point that you need to know. And more importantly, one important differential diagnosis there, that is a renal vein thrombosis, especially if it's bilateral, you can get a AKA also. But in renal vein thrombosis, the patient will typically have a flank pain. And at the same time, the diagnosis can be done with renal vein Doppler. So that's why whenever there is an AKA, don't forget to do a renal vein Doppler, even though most often it will be due to congestion. But some in nephrotic syndrome, it can be due to renal vein thrombosis. So always do a renal vein Doppler. And of course, the treatment for this is different. Here you need to use heparin, either low molecular weight or unfractionated heparin. So that is the idea. So if it's typically due to renal congestion, it's a very common scenario. Give diuretics, they will respond to that. If it's due to renal vein thrombosis, then you need to start with heparin. That is why understanding about this AK is very important. So in minimal change disease, I will not be seeing that much of renal vein thrombosis, rare in minimal change disease. But when you are talking about membranous nephropathy, this renal vein thrombosis becomes very important, because in membranous nephropathy, if the patient comes with AK, even though it can be due to congestion very commonly, but I'll always rule out a renal vein thrombosis, which is very, very important, especially if the patient tells a flank pain. So in exam, it's a stereotypical and prototypic question. Whenever they give a nephrotic syndrome patient coming with flank pain and AK, always think about a renal vein thrombosis, unless proved otherwise. That's all. If they ask you next step, always go for renal vein Doppler, or CT venography is better, but in the setting of high creatinine, I generally avoid CT venogram, a contrast. So I can go for renal vein Doppler, which is much better in these situations. And secondary cause of MCD, secondary can happen in any age. It's not like it will happen only in young age. It can happen in any age. Very important is the drugs. Drugs are extremely important as far as secondary nephrotic syndrome is concerned. And the most important drug of all is NSAIDs. NSAIDs are the most important. Multiple times asked questions. Remember, usually in adults also, analgesic nephropathy commonly presents with massive proteinuria. Apart from poor concentration of the urine, papillary necrosis, all these things analgesics can cause, NSAIDs can cause. But very common presentation in adults as far as analgesic nephropathy is concerned is massive proteinuria. Why they come with massive proteinuria? Because they have some element of minimal change type of nephrotic syndrome. So that is the reason why analgesic nephropathy, apart from presenting with renal papillary necrosis or apart from presenting with concentration defects, they also come with massive proteinuria. So NSAIDs are extremely important from the adult perspective. And it can happen because of bisphosphonates. It can happen because of sulfur drugs like sulfasalazine. But NSAIDs are the most important. Bisphosphonate sulfur can produce, but NSAIDs are very important. NSAIDs are very, very, very important. Apart from that, it is associated with atopy. Some children who's prone for atopy or already having atopy can develop MCD, and immunizations also can develop. After immunization also you can develop MCD, even though it's rare. And at the same time, there are some more causes like cancers. Cancers typically in exam you will develop in a patient who's having a leukemia and lymphoma, leukemia and lymphoma, and at the same time some solid organ tumors also can cause minimal change disease. But in exam you always think about a leukemia or lymphoma, and a child especially can come with a minimal change disease also. I told you already, tumor antigens can produce minimal change disease. This is one example. Leukemia, lymphoma, and even many solid organ tumors can also result in development of minimal change disease. But please don't forget this leukemia and lymphoma. These are some of the important secondary causes. As far as secondary causes is concerned, NSAIDs, tumors. So these are the two things that you need to know for secondary causes if you want to crack the exam questions. Fine. And how you are going to diagnose this minimal change disease? Minimal changes don't need to diagnose anything. I'll tell you one important algorithm which will be useful for exam. Suppose if you're seeing a child who's less than 10 years of age coming with edema and nephrotic range proteinuria, what is the next thing that you're going to do? Next thing you're going to do is start treatment with steroids. That's all. Start treatment with steroids. That's all. Remember, but this child usually will have a normal blood pressure, even though they can have hypertension. Many times normal or a mild increase in creatinine may be there. Normal or a mild increase in creatinine, that is due to the renal congestion, which I told you. So if this is the case and there is no significant hematuria, no macroscopic hematuria, which means no gross hematuria, only some small microscopic hematuria, edema and nephrotic range proteinuria. This is the main problem in a child less than 10 years. You start with steroids straight away. Typically, we start with prednisolone. Standard dose is 1 to 1.5 milligram per kilogram. Full dose we start with, and that's it. Enough. Like you start with steroids, and because we take it as MCD unless proved otherwise, we start treating as MCD. You don't even need a biopsy for this. So just start treating as minimal changes. This is the usual thing that we need to do. Suppose steroids can go for remission. They go for remission, which means you have given steroids, you have tapered steroids. Once you have tapered steroids, they have gone for remission. Then you just observe, no need to do anything. Suppose if you have given corticosteroids, prednisolone, and while tapering or after tapering you have some problem, they do not go for remission. While tapering and stopping, they don't go for remission, or even with steroids, they don't go for remission. So they are resistant. So in this condition, definitely you need to do a biopsy. I mean, usually nephrologists don't do a biopsy. If you take a pediatric nephrologist, they don't do a biopsy. Come to my hospital, like there is separate pediatric nephrology department. This is what they follow. They don't do a biopsy. Straight away they start with treatment. So once they don't go for remission, here is where your biopsy becomes very, very important. So why biopsy is very important? Because you need to rule out some congenital forms of nephrotic syndrome as well. Because it could be some congenital nephrotic syndrome. So that's why to rule out that, you will always need a biopsy. Once you need a biopsy, how can you be sure it's a minimal change disease? In minimal change disease, light microscopy will be normal, immunofluorescence will be negative, complements will be normal as well. There won't be any problem. Electron microscopy will show that typical effacement of foot pros of podocytes. Remember, effacement of foot pros of podocytes is a very, very non-specific finding, which means it is not, even though in pathology textbooks, this is glorified to a great extent. It's not glorified, but it's often the students who glorify it. So why they glorify is because you think that this is very specific for minimal changes. Actually, no, it's not specific for minimal change disease. It can be seen in any other condition. For example, you can see in any other podocytopathy. For example, you can see this in congenital nephrotic syndrome patients. You can see in minimal change disease patients. You can see in focal segmental glomerulonephritis sclerosis patient. You can see in membranous glomerulonephritis patients. You can see in many conditions where you can have effacement of foot pros of podocytes. All these are basically referred to as something called podocytopathies. All these are basically called as podocytopathy. So which means effacement of foot pros of podocytes is not very selective or specific for minimal change disease. Why it is important? Because perhaps everything else is normal. This is the only finding that you see in minimal change disease. That is the reason why it becomes important for minimal change disease. Even though it's not specific, it is the only finding that is seen in minimal change disease. Apart from that, biopsy is not really important. So what are the areas where you don't get a remission? There are three definitions where you don't get a remission with steroids. For example, there is something called a steroid resistant nephrotic syndrome. Steroid resistant nephrotic syndrome. Second, we have something called a steroid dependent nephrotic syndrome. And third one, we have something called a frequently relapsing nephrotic syndrome. Frequently relapsing nephrotic syndrome. So typically for steroid resistant, which means steroid resistant means the proteinuria is not dropping at all. So typically there are definition for how much proteinuria should drop. Typically it should become less than 300 milligram per day. So that is the idea of giving all these drugs. So if it does not become less than 300 milligram per day, or still the patient is having significant proteinuria more than 1 gram per day, even after starting the full dose of steroids. So that's called steroid resistant nephrotic syndrome, where they don't really respond to steroids that much. So for this condition, we start with calcineurin inhibitors. Typically, we start with a cyclosporin, very, very important drug in this situation. For steroid dependent or steroid relapsing, frequently relapsing type. So steroid dependent in the sense, you can imagine like whenever you try and stop the steroids, the proteinuria will increase again, which means they do respond to steroids initially. When you start with steroids, they can have a reduction in the proteinuria to non-nephrotic range and even to lesser than that. But once you start tapering the steroids, lowering the dose, your proteinuria increases again. So that is typically you can remember like a steroid dependent type. Or frequency relapsing, it responds but very transiently. You stop and taper for a few months, once again the proteinuria comes. You stop and taper for a few months, once again initially it responds well, and after stopping also, during tapering also it responds well, but within few months or few weeks it starts, the patient starts getting a new disease again proteinuria. So this kind of frequently relapsing and steroid dependent disorders are better treated with alkylating agents like cyclophosphamide, which is a better therapy. Remember, if cyclophosphamide cannot be used, for example, cyclophosphamide is a very important agent that causes gonadal toxicity. Gonadal toxicity. You have to keep in mind always, which means these are young children, 10 years, 8 years, 2 years old children. If you give cyclophosphamide to these individuals, there is a 20%, 1 in 5 children will lose the gonads. It means the gonads will be fried and gone. So they'll be infertile forever. So if you want to preserve gonads in this, so if your idea is to preserve gonads, then in this situation you can use calcineurin inhibitors like cyclosporin or tacrolimus. Cyclosporin or tacrolimus. It depends. So suppose if you want to preserve the gonads, go for calcineurin inhibitors. If that is not the case, and if you want to treat it very aggressively, then you can go for cyclophosphamide also, depending on what is the clinical situation. So there are separate definitions for what you mean by steroid dependent and what you mean by frequently relapsing type. So for example, if you take what you mean by frequently relapsing type, suppose if there are at least more than 2 relapses that are happening in 6 months, or more than 4 relapses that is happening within 12 months. So this is the definition of frequently relapsing type of MCD. And you have a steroid dependent type of MCD as well. As a steroid dependent is concerned, if there are more than 2 relapses while on taper, that's very important. See, relapsing is different. So they have responded very nicely. After stopping, you get the disease back. So that is, like frequently relapsing. Steroid dependent means while on taper, while on tapering itself, while you are tapering the steroids, that time itself, if you get, that is steroid dependent. Or one more definition for steroid dependent is if you are getting at least 2 relapses within 1 month of stopping steroids. It's all only for study purposes, but understanding is very simple. While stopping steroids, you get relapse. That is more of a dependent type. After stopping steroids, within a few weeks or months, you get a relapse. That is more of a frequently relapsing type. So simple. So more than 2 relapses within 1 month. 1 month of stopping steroids. So this is the definition of steroid dependent type. So, but idea is very simple. So in reality, we don't, it's only for study purposes and for criteria purposes. But apart from that, while on taper, mostly it goes towards dependent. After taper and stopping, if you get very fast, then it's a frequently relapsing type. While they don't respond itself in the first place, that is steroid resistant type. For steroid resistant, go for calcineurin inhibitors. For steroid dependent, you can go for either cyclophosphamide or calcineurin inhibitors. If you want to preserve the gonads, if you wish to preserve the gonads, go for calcineurin inhibitors. One of the closest DDs for minimal change disease is going to be the congenital nephrotic syndrome, which you have to be very clear, and sometimes you need to know about that as well. Okay, so these are all about the minimal change disease which you need to know. Then next thing we have something called the FSGS, that is called focal segmental glomerulosclerosis, FSGS. As far as FSGS is concerned, we have primary forms of FSGS and also secondary forms of FSGS. Secondary forms of FSGS. Primary forms of FSGS is usually idiopathic, as we know, and it's going to happen in males and blacks. Black males, it's extremely common. That is primary focal segmental glomerulosclerosis. And you know why it's called a minimal change disease? Because they don't have any change in anything except for the electromagnetic. That's why it's called a minimal change disease. Why it's called FSGS? Because light microscopy, you see FSGS, focal segmental glomerulosclerosis. You know what you mean by focal, you know what it means. Segmental, you know what it means. Glomerular, what do you mean by sclerosis? So if you see a focal segmental glomerulosclerosis, that is what we call as an FSGS. FSGS is often supposed to be an extrapolation of MCD, where minimal change disease, you don't see any change. If there is a continuous proteinuria that is happening, usually the proteinuria does not happen everywhere in the glomerulus. There will be a proteinuria that is leaking out from some portion of the glomerulus. That portion may go for a reactive change going for sclerosis. So that is what we refer to as an FSGS. So which means you can imagine that FSGS is probably just an extrapolation of MCD in adults. You can call it as an FSGS. It can happen in children also, like congenital FSGS of Finnish type. That's also a type of congenital nephrotic syndrome. So don't worry about that. So FSGS and MCD are almost like twins. So if you don't see any change in light microscopy, you get massive proteinuria, that is minimal change disease. If you see this kind of focal segmental sclerosis along with massive proteinuria or nephrotic range proteinuria, you called as a FSGS. That's all. Apart from that, nothing else. And one more interesting thing that if you go back to the nephritic disorders like PSGN, so IgA nephropathy in light microscopy, you see proliferation. Here there is mesangial proliferation, which you have seen. Where is light microscopy? Yeah, you saw the mesangial hypercellularity here. And then if you move on to PSGN, you see glomerular hypercellularity. You saw some form of hypercellularity. If you move to the crescentic glomerulonephritis, you saw crescents. Crescents are nothing but proliferation of parietal epithelial cells. You saw another crescent is just nothing like a proliferation. Then go to lupus nephritis, class 3 and class 4, basically proliferative types. So what I'm trying to tell is in membranoproliferative, again, you are having some proliferation here. So whenever you talk about nephritic syndrome, typically you are going to call it as a proliferative type of glomerulonephritis. Whenever you see a nephrotic syndrome, like minimal chain disease or even FSGS, you don't have any cellular proliferation. Here in minimal chain disease, the light microscopy is typically normal. Light microscopy is typically normal. And in FSGS, again, light microscopy will not have any proliferation. They'll be having sclerosis, but light microscopy will not show any much cellular proliferation or cellular change. So this is what we refer to as a FSGS. So which means these are nephrotic syndromes which will not have any cellular proliferation. Ashwin is telling this was not taken. I think you are not attended the previous session, Ashwin. From 2:15 I am taking. In the previous session I have covered all those things. And then I think you are attending now only. That's why you are not knowing that. Okay. So FSGS. So nephrotic syndrome usually it will be non-proliferative type. You don't really get that much of proliferation of any cells. But anyways, primary, we don't know the pathophysiology. If they ask you what is the pathophysiology in primary, probably it is due to certain pathophysiology we called as, initially we thought to be something called SUPAR. It's a circulating antigen. It's like a plasminogen receptor. So that is the one that is thought to be the antigen or circulating factor that is actually results in the development of FSGS. On the other hand, minimal chain disease, you don't have any circulating factors, but they thought it's more of a cell-mediated immunity. That's what they thought as one of the important pathophysiological factors as far as minimal chain disease is concerned. But even though it's not elusive, because many of the cases are idiopathic still, we don't know the real cause of how MCD happens. But nevertheless, pathology is thought to be the cell-mediated immunity type. So how we understand cell-mediated immunity as important pathophysiology, because they respond to this immunosuppression well, especially the cyclophosphamidol block the T cell proliferation very much. So probably we think that this could be due to T cell mediated immunity. And apart from that, FSGS is thought to be due to some circulating factor. Why FSGS alone is thought to be due to circulating factor? The reason is because when you transplant the kidney, even in the transplant kidney, there is high risk of getting FSGS again. So which means if it's a local in situ problem, means you should not get the disease again in a transplant kidney. So if you transplant a nice kidney from someone, even that kidney can go for FSGS. Similarly, if you take this non-transplanted kidney, I mean, which means if you take this affected kidney with FSGS and keep it in another patient who is normal, they might not get FSGS, which means even the changes with FSGS may be resolved, or the changes that is already seen will not get worsened, it will be the same. There will be no progression of FSGS. So we believe that there is some circulating component is there, or some circulating factor or some antibody or something is there that is there in the body in MCD or FSGS that is actually causing these changes over a period of time. So that is thought to be super, even though this theory is completely outdated now. Second one, we have the apolipoprotein L1. ApoL1 is there, which is present in chromosome number 22, that thought to be one of the important risk factors. And third is Trypanosoma cruzi has been thought to be one of the important pathophysiological factors. I mean, brucei, sorry. Trypanosoma brucei, which thought to be one of the important pathological features in idiopathic FSGS because it's more common seen in Africans and blacks very commonly. Thought that T brucei may be the reason. But nevertheless, the reason, the pathophysiology behind why you get this kind of massive proteinuria in patients with FSGS is the fact that is due to alteration of visceral epithelial cells. Alteration of visceral epithelial cells, that is the podocytes, that is resulting in retraction of podocytes, vacuolation of podocytes, and becoming sausage-shaped food process. Food process will be damaged, so something is happening here. But that's why we call idiopathy. We don't know the clear-cut cause of why this is happening. As far as secondary is concerned, secondary can be due to various pathophysiology. One, the same alteration of visceral epithelial cells. That could be the reason for secondary. Or secondary could be due to glomerular adaptation to hyperfiltration. Glomerular adaptation to hyperfiltration. And third one is loss of nephrons, reduced nephron mass. This could be the reason. So as far as secondary causes that alter the visceral epithelial cells are concerned, so there are some drugs that alter the porosity and alter the structure of the visceral epithelial cells, like heroin. I feel that heroin is the most important because it's asked in the first decade of 21st century. In the 2000 to 2010, this question was extremely common. After that, I don't know why they stopped asking this. Heroin is such an important question. Lithium can do that, and even bisphosphonates can do that. If you see closely, there are some drugs that have overlap with MCD, bisphosphonates, isn't it? So there will be so many causes that will be having overlap. And second, a lot of infections can do that. Whenever there is an infection, the first thing that you need to know is HIV. We know that HIV is equal to FSGS in exam. Whenever they tell a nephropathy with HIV and if they ask you what type of glomerular disorder you will see in HIV, that is collapsing type of FSGS, is a very common question. And you can get with some other infections like parvovirus B19, rarely, or you can get with cytomegalovirus and Epstein-Barr virus. And at the same time, there are some genetic mutations that can result in development of FSGS, especially congenital FSGS, nephrin mutations. Typically in exam, you will get this NPHS1 mutation, which produces that Finnish type of FSGS. Then it can be due to podocin mutations, or it can be due to actin mutations, alpha-actinin 4 mutations. All these things can result in development of congenital forms of FSGS, usually. But as far as exams are concerned, the two things that are very important are heroin and HIV. These are two things that are extremely important. Other things, maybe nephrin is important, and NPHS1 is important because it causes congenital Finnish type of FSGS. But in India, you don't get this kind of problem. So I don't think they will ask in Indian exams. But nevertheless, you have hyperfiltration. What are the conditions that produces glomerular filtration, glomerular adaptation to hyperfiltration? Which means conditions that produce hyperfiltration. Classically, diabetic kidney disease, diabetic nephropathy or diabetic kidney disease can progress towards FSGS. And apart from that, long-standing hypertension, especially severe hypertension, can result in FSGS, because hyperfiltration means you are filtering more and more, that will damage the filtration slits and they can result in more leakage of proteins. And third is morbid obesity. Very, very important point. Can result in development of FSGS over a period of time. And anabolic steroid use. And finally, we have sickle cell disease. So some condition which can predispose to development of FSGS. And reduced nephron mass. Many conditions can have reduced nephron mass, like low birth weight individuals, preterm individuals are at high risk of developing FSGS in the future. And if there is a unilateral agenesis of the kidney, which means only one kidney is there which has to take the entire load, so hyperfiltration can go for FSGS. Or post nephrectomy, post unilateral nephrectomy. Don't tell this to the kidney donors, because otherwise they won't donate the kidneys. So after nephrectomy, because only one kidney has to take care of the entire load, so they might go for hyperfiltration and they can go for FSGS. If they ask you the side effects of kidney transplantation, one important side effect in the donor after kidney transplantation is a slightly increased risk of FSGS. Apart from that, there is no much problem. Third is a vesico-ureteral reflex, VUR. VUR typically produces cortical scarring, and that is the reason why they get FSGS. And similarly, advanced kidney disease itself can progress towards FSGS, because again, hyperfiltration, which means only 2-3, out of 10 nephrons, as I told you, only 2 is remaining means, and the 2 has to take care of the entire load, and they can go for FSGS. So these are some of the causes where you can get focal segmental glomerulosclerosis. Remember, in patients who are having these forms of FSGS due to damage to the visceral epithelial cell, patients who are having primary alteration of visceral epithelial cell, will have some peculiar effects. Like, for example, they will, because there is a primary alteration of visceral epithelial cells in these guys, there will be a massive proteinuria. Usually the proteinuria will be nephrotic range, more than 3.5 grams per day. And even the hypoalbuminemia will be severe. It will be for less than 2.5 grams per deciliter. Hypoalbuminemia also will be very severe, and proteinuria also will be very severe. And if you see electron microscopy, there will be more than 80% glomerulus and podocytes will show effacement of food process. I can just write more than 80% effacement of food process of podocytes will be there. In which you have to see is in patients in non-sclerotic glomerulus. That's very important. Non-sclerotic glomerulus. Remember, if you see in the sclerotic glomerulus, I told you it's FSGS. FSGS means it's focal segmental glomerulosclerosis, which means only less than 50% of the glomeruli will be affected. So that affected glomeruli, if you see, definitely there will be effacement of food process of podocyte. There's no fun in seeing that. But if you see a non-sclerotic glomerulus in electron microscopy, even that will show more than 80% effacement of food process of podocytes. So edema often will be sudden and severe in these patients. Edema will be often be sudden and severe in these patients. But when you take the other two category, so those patients who are not having alteration of visceral epithelial cell, or those who are having adaptive FSGS due to low nephron mass or due to hyperfiltration, this group of people can name it as adaptive FSGS. Those who are having problems in hyperfiltration or due to reduced nephron mass. So this kind of adaptive FSGS typically tends to have milder proteinuria, less than 3.5 grams per day, and a less severe hypoalbuminemia, more than 2.5 grams per deciliter. And at the same time, they tend to have less than 80% effacement of food process of podocytes in non-sclerotic glomerulus. And at the same time, edema will be gradual and progressive edema. Gradual and slowly progressive edema. Clear? So this is how the adaptive FSGS behaves. This is some small thing that you need to know. So whatever I told you, in patients who are having primary alteration of visceral epithelial cell, they're going to have massive proteinuria, severe edema, and sudden edema. In patients who are having adaptive type of FSGS without primary alteration of visceral epithelial cell, they're going to have a slowly progressive edema and a subnephrotic range of proteinuria only. They will not have a typical nephrotic range of proteinuria, which is very important to know. So light microscopy, as I told you, you'll be seeing FSGS only. There's nothing much you're going to see in electron microscopy. Once again, you're going to see that effacement of foot process of podocytes along with glomerular sclerosis is what you're going to see in electron microscopy. Immunofluorescence will be typically negative, except in selected cases, and complement levels will be typically normal. If you see, except for this one light microscopy change, everything will be similar to that of what you see in the minimal change disease. That's why I told you the FSGS is just an extrapolation of what is in the minimal change disease. That's all. In light microscopy, you have 5 histological types. 5 histological types of FSGS. One is going to be the FSGS NOS type, that is not otherwise specified type. This is the most common type basically. Which means, what do you mean by not otherwise specified? You have remaining 4. If some form of FSGS does not fit into any of the other types of FSGS, that's called FSGS NOS. Then we have a perihilar type of FSGS. Then we have a cellular variant of FSGS. Then we have a tip variant of FSGS. Then we have a collapsing type of FSGS. Collapsing type of FSGS. Usually, this perihilar type will be of adaptive type of FSGS. Adaptive type of FSGS. And cellular type and tip variant will be usually due to alteration VEC. Alteration of VEC. And collapsing type of FSGS are variable. Collapsing type and your NOS is basically variable. Clear? So if they ask you an exam, the classic example of where you see this adaptive FSGS, they will typically cause a perihilar type of FSGS only. Clear? Hello? Hello? சொல்லுங்க. ஆமா 27th தான் சொல்லியிருக்காங்க. அப்படிதான் போட்டிருக்கு குரோமால. நான் வந்துச்சுன்னா நம்பருக்கு கால் பண்றேன், என்கிட்ட இருக்கு. Thank you. Perihilar is a classic example of adaptive type of FSGS. So that might be a question in exam. Typically, they come with a subnephrotic range proteinuria only. And they'll come with normal serum albumin most of the time. So if they ask you, this is a very common question in exams. I think one question was there in AIMS 2014 or 15. Even though guidebooks, don't believe the guidebooks. Guidebooks will give only questions that are answered by that particular author. Otherwise, if they don't know the answer, they will eliminate that question. So don't worry about the guidebook. So this is one question that's asked in AIMS 2014-15, I guess. So typically they gave which variety of FSGS will have a subnephrotic range proteinuria or a normal serum albumin. And that time there was a lot of ripple saying it's atypical FSGS. No, nothing like that. So it's nothing but it's different, which what I have told you already. It must be easy now. So they produce subnephrotic proteinuria because it's an adaptive type of FSGS and they are normal serum albumin. And basically all other things will come with a typical nephrotic range proteinuria only. They'll be nephrotic. This also will be nephrotic. But other two are variable. As I told you, they can be nephrotic or subnephrotic. Doesn't matter because they can happen in both adaptive as well as changes in the visceral epithelial cell. Doesn't matter. So now coming on to the biopsy. So what will be the typical biopsy finding you will see? So you will see the changes predominantly in the vascular pole. That is why we call it as a perihilar variant. Whatever changes I've told you for FSGS, the glomerulosclerosis, will be typically seen mostly in the vascular pole. So we know it's a focal segmental. If it's segmental, we need to know which area it's affected predominantly. So, you know, what do you mean by segmental? Segmental means a part of the glomerulus is involved. So that's what we call it as segmental. So this biopsy difference is based on which segment is affected. That's the idea. So vascular pole is affected. Why vascular pole of the glomerulus? What do you mean by vascular pole? So when you take a glomerulus, you know, this is going to be the vascular pole and this is going to be the tubular pole. So this is what we refer to as a tubular pole. This is what we call it as a vascular pole because that faces the vessels, the glomerular vessels. So if the vascular pole is more affected, you can also indirectly think like if the vascular pole is more affected, very often it will be due to hyperfiltration. That's why I'm telling you it is due to adaptive FSGS. Adaptive FSGS very commonly affect the vascular pole, and that kind of vascular pole involvement is what we refer to as a perihilar variant of FSGS. And when you come to the cellular variant, so they will be associated. They will be having some area FSGS. It's variable area. It will not be at a typical area, but they might be having associated endocapillary proliferation, plus or minus endocapillary proliferation. That's the characteristic feature of cellular variant. That's why the name cellular came, because they'll be associated. Some element of endocapillary proliferation may be there. And if you have a tip variant, typically they are going to affect the tubular pole. You know what is the tubular pole? If that area is segmentally affected, that's called a tubular pole type of FSGS, tip variety of FSGS. And if it's collapsing type of FSGS, usually the glomerulus will appear as if they have imploded on itself. It's an implosive type, and there will be an entire tuft collapse will be there. And again, which area will be affected will be variable. If you don't see any of this, you call it as NOS, not otherwise specified, which means you don't see in vascular pole, you don't see endocapillary proliferation, you don't see tubular pole related issue, you don't see a tuft collapse or an implosive type of FSGS. By diagnosis of exclusion in histology, you can go for NOS type, which is the most common type, not otherwise specified. As far as prognosis is concerned, so tip variant is tip 1 is the one that is supposed to be having the best prognosis. I can write here the best prognosis. You get the tip variant, which means this is the one that has maximum response to steroids. Whereas the collapsing variant is the one that is having the worst prognosis. They do not respond to steroids at all in the first place. And all these first three, NOS, perihilar variant and cellular variant, they have an average prognosis. They don't have the best, they don't have the worst, they have an average prognosis, and the response depends on multiple other factors as well. Clear? So these are the 5 different types. The usual questions will be best worst prognosis, and where will you see vascular pole versus tubular pole. Depending on that, you can tell perihilar versus tip variant. And what will you see in collapsing variant? That's a tuft collapse. Usually in HIV and heroin, very commonly you will see a collapsing type of FSGS only. They'll typically tend to produce a massive tuft collapse, and that will result in fast progression of renal failure and very bad prognosis, and they don't respond to steroids as well. As far as treatment is concerned, the primary forms of FSGS, you're going to use immunosuppression, especially glucocorticoids and other levels of immunosuppression you can use. For secondary types of FSGS, you have to just treat the underlying cause. Treat the underlying cause. That's the treatment of secondary types of FSGS. Apart from that, only for primary FSGS, primary forms without any underlying cause, you can think about giving an immunosuppression, steroids. Otherwise, for secondary cause, it's just the treatment of the underlying cause. So I think FSGS is done. FSGS is very important for exams because so many questions are there. In general, usual certain areas which is very commonly asked in exams is heroin, HIV, severe hypertension, morbid obesity, then vesicular reflex, sickle cell disease, nephrin type, Finnish FSGS. These are the usual things you will get in exam. So at least remember these things and go before going to exam. And if you don't understand this entire histological picture, just tip is best, collapsing is the worst. So at least these 2 things, if you know, that's going to be more than enough. These are the important points as far as exams are concerned. Then we have membranous nephropathy. Previously, it was called as membranous glomerulonephritis, but because it doesn't cause nephritic presentation very commonly, very, very rare, less than 5% will come with nephritic presentation. Commonly, they will come with nephrotic presentation only, more than 95%. So that's why it's usually called as membranous nephropathy rather than membranous glomerulonephritis. And membranous nephropathy, classically, like the name why it came because of light microscopic findings. So if you take the light microscopy, you will see some classic findings. Like for example, there will be a thickened base membrane, which will appear as if the base membrane duplication. So in exam, you see a nephrotic syndrome coming in the base membrane duplication. That is, it looks like as if the base membrane has thickened so much. So base membrane has duplicated multiple times. So base membrane duplication and thickened base membrane is very classic finding, but there will be normal cells. There will be no increase in the number of cells. Exception is some tumor-related membranous nephropathy, where you might see some cellular proliferation, but overall you might not be seeing any cellular proliferation. So they'll have generally normal cells only. Clear? That's really, really important to know. And how will you differentiate from membranoproliferative? In membranoproliferative, the cells will be increased. As I told you in the previous section, that's why it's called a membranoproliferative. the number of cells will be increased in membrane proliferative along with thickened base membrane, and they will produce a split appearance of the base membrane that are characteristics which are membrane proliferative. But in membranous, the only finding that you'll see is a diffuse thickening of the base membrane, which is also referred to as base membrane duplication, but the number of cells will be typically normal in this situation. I'll tell you the electron microscopic findings and immunofluorescence findings after some time. But nevertheless, you need to know the etiology of membranous nephropathy. As far as etiology is concerned, once again, you can split into primary forms of membranous nephropathy and secondary forms of membranous nephropathy. As far as primary forms of membranous nephropathy is concerned, usually you will see primary forms in young adults, very common in Caucasians, like how FSGS is common in blacks. This is a Caucasian disease, which means if you go to Europe, most of the case of Northern Europe, Canada, and Iceland, Finland, Sweden, all this membranous nephropathy is quite common, primary membranous. If you go to USA, African, Caribbean population, those patients all usually get FSGS very commonly. But again, like the most common debates will start, and many students will start the most common debates, which is the most common type of nephrotic syndrome in the world. No, it depends on what book you study. For example, if you take an Oxford textbook of medicine and any Oxford related textbook, they'll give membranous nephropathy as the answer because with their population, it is most common. If you go for US based textbooks like Robbins or probably Harrison, they might give you FSGS as common because according to their studies, which was done in US, FSGS is common. But I don't know which to answer. It all depends on the local population, but Indians always keep arguing about which is more common. So that's not at all important. It's always the diagnosis that makes sense. It's not the most common that makes sense in any way. Anyways, I believe if you want to answer, you can answer FSGS, but I don't really into all this stuff. So young adults, Caucasians, idiopathic, you don't know the cause, or you don't know that, there are some antibodies are there, but you don't know why these antibodies are there. There is some antibody that's circulating. So that there are two antibodies which are very important, idiopathic MGM or primary MGN. So in books, they will call it as IMGN, or you can call it as a PMGN. So the common name is IMGN. So if you call IMGN, means itself is an idiopathic primary membranous nephropathy. In IMGN, the usual antibodies or two antibodies are there. Based on the antigens, what are the two antigens? One is called a PLA2 receptor. I told you this is a M-type PLA2 receptor. M-type PLA2 receptor. So that is one antigen that is very commonly seen, against which antibodies are developed. And second is the THSD7A. It's a thrombospondin type receptor. THSD7A. This is not seen very commonly, but it's very important. And the antibodies that are seen are anti-plateau receptor antibody. And the second is anti-THSD7A antibody. As far as the frequency is concerned, it is seen only in 10%, but 80% of the people with IMGN will have anti-plateau receptor antibody, which means this becomes very, very important for exams, very commonly asked. And remember, this is an intrinsic antibody. These are not planted antigens. These are not circulating immune complex. These are in situ antigens that are present in the glomerulus. So if you take the structure of the glomerulus, it's very simple to understand. So if you have this kind of capillaries with fenestrations, let me draw that. Capillary fenestrations, and if you put a base membrane, along with that, if you have this kind of foot cross of podocytes, I can draw something like this. Foot cross of visceral epithelial cells. We know these antigens, for example, PLA2 receptor antigen, or this phospholipase A2 receptor or THSD7A, all these things are basically present on the foot cross of podocytes only. These are antigens that are present on the foot cross of podocytes. So, usually why they're called antigens? Because we'll have an acid antibody. Not all will have antibody. Very few will have circulating antibody against. We don't know why these antibodies are there. Few will have circulating antibody. These antibodies are going to bind with this antigens that represent the foot cross of podocytes, and they form a local immune complex deposition. Local immune complex formation. And remember, these antibodies, while circulating, they are not really going to bind with their antigen. Only locally they bind with the antigen, and that is the reason why circulating complements are not really activated, even though in this area complement may be deposited. But in reality, since it's not a circulating immune complex are formed only locally in that particular area against that intrinsic antigen area. So complements will not be decreased usually. Complement levels will be generally normal in the setting of a IMGN, primary membranous glomerulonephritis. At the same time, you can see nicely they form this kind of granular deposits, granular subepithelial deposits only, subepithelial deposits, which means we know this space is the one that we called as subepithelial space, and this space is the one that we called as a subendothelial space below the endothelium. This is what we refer to as subendothelial space. And more importantly, more than calling subepithelial deposits, they are more often called as an epimembranous deposits. That's what the name, typical name that is given. It's, even though it's subepithelial, but more often it's called as the epimembranous deposit because it's above the membrane. So that's where it's deposited. These antibodies will go there and form immune complexes. And these immune complexes will activate complement and they will result in base membrane edema. And chronic base membrane edema will result in subsequent base membrane proliferation and thickening. So that will result in thickened base membrane. And this reactive thickening of the base membrane will typically extend in between the foot cross of the podocytes as well. And these are what we refer to as epimembranous spikes. This is a characteristic electron microscopic finding where you see the classic spike and dome appearance. So what are the spikes? These spikes are nothing but the spikes of base membrane that you see that are having a reactive proliferation. It's not a cellular proliferation, this is an acellular structure, so you cannot call it as a proliferative glomerulopathy. So there is a reactive base membrane thickening. Along with that, you are seeing a dome of immune complexes that is present beneath the foot cross of the podocytes, which later on in chronic conditions, it will actually damage the foot cross of podocytes, actually causing vacuolation, retraction, and disappearance of the foot cross of podocyte, resulting in development of nephrotic syndrome and massive proteinuria. That's what happens in this patient with membranous nephropathy. So these are the classic findings of IMGN. So in idiopathic membranous nephropathy, this will be the typical feature. And at the same time, as I told you, the complement levels will be typically normal in the blood because it's not a circulating immune complex, it's a localized immune complex against a localized antigen. So there's no diffuse complement activation, so there will be normal complements only in this situation. As far as secondary is concerned, secondary can be completely variable, even though the light microscopic findings show membranous nephropathy pattern. But you might not really get all these things. Antibodies may not be there, and antibodies may not be there. It will not be there usually. At the same time, you might not get this typical epimembranous spike and dome appearance, or you might not get this normal complement. So this kind of things may not be there in secondary membranous nephropathy. But the light microscopic findings will be similar. So that is why doing an anti-plateau receptor antibody is quite important, because if you have an underlying cause straightforward like a malignancy or something else which I'm going to tell, you do not do an anti-plateau receptor antibody. But if you don't have a cause, but you have a membranous nephropathy type of picture in light microscopy, then you can try doing an anti-plateau receptor antibody. They're very specific for idiopathic positive. You can straight away think that it is a idiopathic membranous nephropathy. That's all. As far as secondary disorders are concerned, infections are very, very important. So there are so many infections that typically produces this type of membranous nephropathy. One is hepatitis B virus. This becomes on the top of the chart. If they ask you most common type of renal involvement that is seen in hepatitis B virus is membranous nephropathy. It can cause MPGN also, but very common is membranous nephropathy only. Remember, even if they ask you the most common extrahepatic manifestation of hepatitis B virus, in that also I'll be answering it is glomerulonephritis only. Glomerulonephritis becomes the most common extrahepatic manifestation of HBV. Cryo becomes most common extrahepatic manifestation of HCV. In the glomerulonephritis, as far as HBV is concerned, it is usually membranous form, then MPGN form. In HCV, it is MPGN form type 1, then MGN form. So HIV can produce this. Many other infections like syphilis can do this. Many other infections like toxoplasmosis can do this. If they ask you in toxoplasmosis, what you will see, it is membranous only. The syphilis, what you will see, it's membranous only. HIV, you see membranous. And Plasmodium malaria is there. It can also cause membranous, but very commonly it causes MPGN more than MGN. So I can rub Plasmodium malaria here, but nevertheless it can cause MGN as well. And second is variety of autoimmune disorders can produce, like connective tissue disorders can produce membranous. I've already told you multiple times, rheumatoid arthritis will not affect the kidneys. If they affect the kidneys, they will either produce amyloidosis, which is the most common involvement as far as rheumatoid arthritis is concerned. After that, amyloidosis, second most common is membranous nephropathy. So any CDD can produce membranous. The best example for that is SLE. Class 5 lupus nephritis is basically membranous type only, which we have discussed already. And apart from that, we have IBD, ankylosing spondylitis, which can also cause membranous nephropathy, but rare, not very important. And what is more important for exams is the solid organ tumors. Remember, especially solid organ tumors in elderly, they can produce membranous nephropathy, which is a very important thing. Remember, solid organ tumors in children, mostly they will cause minimal change disease, but solid organ tumors in elderly, adults, very commonly they will produce membranous nephropathy only. So it could be anything. It could be colon, it could be breast, it could be prostate, it could be pancreas. Anything can do that. But usual exam question is colon if it's a man or a female, if it's breast if it's a female. So colon is the most important as far as exams are concerned. Even there are some Western questions. For example, if you go to UK and start writing PLAB exams and all, in PLAB exams they will give usually the patient, a 63-year-old male patient coming with massive nephrotic syndrome, nephrotic range proteinuria. NS means nephrotic syndrome. Do a biopsy, you see a membranous nephropathy. Biopsy showing membranous nephropathy. What is the next step? They will ask you. They ask you what is the next step. Usually in PLAB exams and all, the answer should be colonoscopy. Colonoscopy will be the next step. That's all. So this is really, really important because you rule out a cancer. Any elderly with a biopsy-proven biopsy-proven membranous nephropathy is equal to cancer unless proved otherwise. That's a pretty important point. So in exam, young patient with nephrotic syndrome showing membranous nephropathy in biopsy, think about an infection or a probable malignancy, but infection is having more weightage. A young adult patient with nephrotic syndrome showing a biopsy-proven membranous nephropathy, think more of a cancer-producing membranous nephropathy. So in that, colon cancer is on the top of the chart. So that's why you have to do colonoscopy in most of these guys. So as far as secondary nephrotic syndrome is concerned, you might not see the same change. For example, the complements might be variable. Electron microscopy may not show the same exact epimembranous spike syndrome appearance. Comps variable usually decreased. You can think what will happen in SLE patients. Generally, it will be decreased only, isn't it? Complements. So it's variable. So other findings are also variable. And treatment, here you don't give immunosuppression. You need to treat the underlying cause. As I told you multiple times in the past. You're just going to treat the underlying cause. As far as the idiopathic MGN is concerned, the treatment is typically immunosuppression. And immunosuppression, what we typically follow is the Ponticelli protocol. That's what we follow. It's called as Ponticelli protocol. There is a separate protocol given by Ponticelli. So as far as Ponticelli protocol is concerned, we give alternative alkylating agent versus steroids. For example, how will we split? You are going to give this protocol for 6 months. So in that, months 1, 3, and 5, and months 2, 4, and 6. Second month, 4th month, and 6th month. Months 1, 3, and 5, you will give methylprednisolone initially a pulse dose in day 1, 2, 3. 1, 2, and 3rd days of a month, you will give methylprednisolone IV pulse dose. That will be followed by a oral prednisolone for remaining 27 days. 27 days, I'll be giving a oral prednisolone. I'll write it better. Followed by a oral prednisolone for 27 days. And in months 2, 4, and 6, we'll be using either a cyclophosphamide or chlorambucil. Currently, chlorambucil-based regimens are outdated. Cyclophosphamide is the one that is preferred right now. Or alternately, you can give a chlorambucil. Remember, cyclophosphamide is available oral also. Oral cyclophosphamide also can be given. In your pharmacy, if you are working in a private hospital, you can go and ask for Cytoxan. Cytoxan is cyclophosphamide only. So cyclophosphamide is the one that is preferred as of now. So Pondicherry protocol is nothing but alternating steroids and alkylating agent, cyclophosphamide. So this is what you're going to use as per the Pondicherry protocol. And you need to know how the primary idiopathic membranous nephropathy presents very commonly. So primary idiopathic membranous nephropathy typically comes with gradual onset edema, unlike your minimal change disease, which typically comes with a sudden onset edema. This edema is more of a gradual onset. I don't know why examiners are very fond of this. They generally have a gradual onset edema. Maybe one reason why they wanted to ask this question is because in FSGS primary, you see a primary FSGS, where is that? Usually, you will have a sudden and severe onset edema if it's a primary FSGS. On the other hand, if you go for a primary membranous nephropathy, it's quite different. So it means this is a clinical finding that can actually help you understand the probable underlying nephropathy. So that's why probably the examiners are very obsessed with this question, gradual onset edema. It's very classical of a primary membranous nephropathy. And similarly, like how you saw in minimal change disease, 25 to 50% patients may have a microscopic hematuria, which is quite possible because it's a glomerular disorder. And most of the times they'll be having a normal or a mildly increased BP only, like your minimal change disease most of the times. But due to unforeseen reasons, any diagnosis of membranous nephropathy, as I told you multiple times in the past, any diagnosis of membranous nephropathy means there is a significantly increased risk of hypercoagulability. Significantly increased risk of hypercoagulability, especially renal vein thrombosis. Any membranous nephropathy patient coming with flat pain, you take it as renal vein thrombosis unless proved otherwise. There is an extremely high risk of hypercoagulability due to many unforeseen reasons in membranous nephropathy patients. The prognosis is different depending on the level of proteinuria. Usually 1/3 will go for complete remission, 1/3 may progress, 1/3 may remain the same, and 1/3 may worsen. So this is how the progression will be. 1/3 will completely go for remission, 1/3 will be remaining the same, no change. 1/3 will in fact worsen and they will develop into CKD. So this is the prognosis. So prognosis is very variable, but you can consider the risk. Based on the amount of proteinuria and other factors, you can tell the membranous nephropathy patients, IMGN patients, as low risk or intermediate risk or even high risk. High risk, intermediate risk or high risk. So when you call it as a low risk, whenever the patient is having a normal serum creatinine, you call a low risk. Intermediate risk, normal serum creatinine. Whenever the serum creatinine is increased, always this patient will come under a high risk. This is the most important point, number one. Apart from that, the urinary proteinuria will be less than 4 grams per day. In the setting of a low risk patient, 4 to 8 grams per day. In intermediate risk, more than 10 grams per day. In high risk, this is also important point. More than 10 grams per day is more than 8 grams per day is high risk. Very severe proteinuria. And usually for low risk patients, you will give only conservative treatment. You don't need to start with aggressive immunosuppression. Even if it's a idiopathic MGN, IMGN, you need not start aggressively. You just give a conservative treatment, that's enough. Suppose if they deteriorate towards intermediate risk or high risk, if they progress, then you can start with immunosuppression, which means this low risk patient morphs into intermediate risk or high risk, then you can go for a immunosuppression. Otherwise, there is no need to give immunosuppression. Progresses or deteriorates, then you can give immunosuppression. Otherwise, you just give conservative treatment. So for intermediate risk patients, you are going to try conservative treatment for at least 6 months. You need to try conservative treatment for 6 months. That's what you're going to do in intermediate risk patients. During that, after that 6 months, at least you try for 6 months. After the 6 months, if they remain the same, or if they progress, or if they deteriorate, then you can start with immunosuppression. Which means in conservative treatment, they have to improve. If they don't improve, and if they remain the same or if they progress, you have to start with immunosuppression. You straight away start with immunosuppression if the patient is having a high risk. Usually conservative treatment does not work that much in a high risk patient. Straight away start with the immunosuppression in this patient. That's very, very important. So low risk, conservative treatment is the mainstay. If they worsen further, then you can start with immunosuppression. Intermittent risk, if they remain the same or if they don't improve, then you give immunosuppression. For high risk patients, straight away start with immunosuppression. Which means, what if a low risk patient remains under low risk? You don't do anything, just continue the conservative management. The low risk patient remains as low risk and it doesn't worsen. Even if it remains the same, also you just continue with the conservative protocol only. So, what immunosuppression you give? This immunosuppression is what we studied here, the Pondicelli protocol. So, usually in exam, if you get one question, usually the question will be based on the Pondicelli protocol only. So, that's what they're going to ask. So, this is IMGN. IMGN is very important for exam. Secondary causes, usually in exam, what they will expect is three things: HBV, SLE, colon cancer. So, HBV, SLE, colon cancer. HBV, SLE, colon cancer. HBV, SLE, colon cancer. These are three things that you need to know for exams. Very important. Fine. I think it must be clear. Is it clear? Membranous nephropathy, FSGS, and MCD. What are three things I've told you? All these three things are podocytopathies, where they affect the podocytes, typically. Very important. And classically, you have one more condition where you might have this kind of organized deposits. And before going for organized deposits, let us see malignancy related problems. So if you have a malignancy, and what are the glomerulopathies you can get? So for example, it could be either due to malignancy itself or due to treatment of a malignancy. So for example, most common, if they ask you malignancy related glomerulopathy, it will be membranous glomerulonephritis only. MGN or MN, the membranous nephropathy, will be the most common malignancy related association. So MGN can be seen in patients who are having solid organ tumors, as I told you, or it can happen after a hematopoietic stem cell transplant. Both can result in development of membranous nephropathy. Or after MGN, you have MCD also, minimal change disease also. Minimal change disease is very important, especially for hematological cancers. Very important is Hodgkin. Even though I didn't mention that, I mentioned as lymphomas. So Hodgkin is extremely important, which can cause MCD. In exam, a patient with Hodgkin disease developing a membranous minimal change disease like picture, developing a nephrotic syndrome is equal to MCD. That's how they set the question in exam. That's how they frame it. Hodgkin lymphoma patient developing significant proteinuria and edema. Go for MCD as the diagnosis. That will be the diagnosis usually. Or very rarely, it can be due to solid organ tumors, but very commonly, childhood solid organ tumors, very commonly they can produce minimal change disease. And MPGN can happen. As I told you, MPGN, especially the type 2 and type 3 MPGN, I told you, very commonly it happens after leukemia or lymphoma, especially hematological cancers. Very commonly CLL and multiple myeloma. Chronic lymphocytic leukemia and multiple myeloma. Or malignancies can result in something called a TMS also, that is thrombotic microangiopathy. So thrombotic microangiopathy can happen usually due to treatment of a cancer. And more importantly, the first point that you need to know is calcineurin inhibitors. Calcineurin inhibitors can produce a thrombotic microangiopathy, which is a very, 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 very important point. Calcineurin inhibitors can produce a thrombotic microangiopathy. Extremely important point. CNI. So calcineurin inhibitors can also produce thrombotic microangiopathies like HUS-TTP complex after your transplant also, because after transplant we start with calcineurin inhibitors very commonly. So that's very important for exams. So second, after a hematopoietic stem cell transplant, you can get thrombotic microangiopathy, or you can get after your anti-VEGF therapy like ranibizumab or bevacizumab. Sometimes you can get after anti-EGFR, which is usually used in lung cancers. We have studied in lung cancers in erlotinib after anti-EGFR therapy. Anti-EGFR therapies also can result in that, and many tyrosine kinase inhibitors and mTOR inhibitors can also result in development of thrombotic microangiopathy. I mean the HUS-TTP complex, HUS-TTP like picture. They can be caused by this treatment of a cancer. So very important. So the malignancy related glomerulopathies, in that the most important being colon cancer and MGN, Hodgkin disease and MCD, and calcineurin inhibitor and thrombotic microangiopathy. Extremely important. And they can produce amyloidosis. For example, multiple myeloma can produce amyloid kidneys also. So it all depends what you're really seeing in this particular situation. And apart from that, we have some glomerular disorders with organized deposits. Glomerular disorders with organized deposits. Organized deposits. So this is a new terminology that is coming up. So that's why I thought I would tell, because in exam, if they ask you, many students may not be able to answer, but you will be able to answer, because there is something called glomerular disorders, organized deposits. So what do you mean by glomerular disorders with organized deposits? When you suspect glomerular disorders with organized deposits, whenever you have a mesangial expansion, mesangial hypercellularity with mesangial expansion, in the sense you will be having a kind of extracellular matrix within the mesangium. So that's what I called by mesangial hypercellularity and expansion. Expansion here stands for a kind of increased extracellular matrix in the mesangium. Increased extracellular matrix within the mesangium. So this is where you should typically suspect that the patient is having a glomerular disorders with organized deposits. So there are many disorders out there. I'll just give you the algorithm because I'm running out of time. So the first one is the congruent stain, because the most important is amyloidosis here. So if congruent stain is positive, of course, there is only one possibility. It must be amyloidosis. There's no doubt about that. To further tell what is the type of amyloidosis, you stain for the light chains, because in amyloidosis, only two things can produce this renal involvement. One is AL type of amyloid and second is AA type of amyloid. Other type of amyloid like transthyretin forms, the beta-2 microglobulin forms usually does not cause renal involvement. So only AL and AA will produce renal involvement. So if you want to know, you can understand the history also at the same time. Just stain for the light chains. What are the light chains I'm going to say? I'm going to stain for kappa and lambda. If light chains are positive, then it will be AL type of amyloidosis. If light chains are negative, then I can go for AA type of amyloidosis. As simple as that. Simple. That's all. Usually AL type of amyloidosis, if you see in electron microscopy, is very, very important, because whenever you use the word organized deposits, these organized deposits can be characterized only based on electron microscopy. As far as electron microscopy is concerned, this AL type of amyloidosis will be having 8 to 15 nanometer kind of fibrils, because they'll be asking you the difference between fibrils, microtubules, and all such things. So usually they'll be producing this 8 to 15 nanometer kind of fibrils here. And as far as AA type of amyloid is concerned, they are also going to produce 8 to nanometer kind of fibrils, which means the characteristic feature of amyloidosis in electron microscopy is this 8 to 15 nanometer kind of fibrils, which is very, very important. Fine. Then suppose if the congruent stain is negative, and usually we call it as a non-amyloid type of deposit, most of them will be staining positive for methenamine silver, but that doesn't mean. But next step is immunofluorescence. So now immunofluorescence positive or immunofluorescence negative. Suppose if immunofluorescence is positive, it is typically immunoglobulin derived deposit. Suppose if immunofluorescence is negative, then it is non-immunoglobulin derived. Non-immunoglobulin derived deposit, that's all. Non-immunoglobulin derived deposits, you have three types, and all these things can be characterized only by electron microscopy, but in light microscopy, you can characterize to some extent. For example, there is something called a banded collagen deposits. Banded collagen. Whenever you see this kind of banded collagen, and you know what are the collagen stains, like trichome stain. So if you use that kind of stain and find there is a banded collagen within the glomerulus, this goes towards something called a collagenofibrotic type. The separated data, very commonly they'll come like a nephrotic presentation only. That's called a collagenofibrotic type. Or if there is no banded collagen, there can be two other possibilities, but both of them need electron microscopy to diagnose. One is called a diabetic sclerosis or diabetic fibrillosis. Can be called by anyway, diabetic sclerosis or diabetic fibrillosis. Typically in electron microscopy, they'll have 5 to 20 nanometer fibrils. That's why it's called a diabetic fibrillosis also. Typically, they'll produce a 5 to 20 nanometer fibrils. And second one is something called a fibronectin glomerulopathy. Fibronectin glomerulopathy. Fibronectin glomerulopathy, typically they will produce this 10 to 15 nanometer fibrils. And there are separate stains where you can identify this fibronectin. And at the same time, you might have usually fibronectin will be congenital condition, like autosomal dominant condition, very commonly. But diabetic fibrillosis, very commonly it happens in the patients with type 1 or type 2 diabetes mellitus. So based on history itself, you can differentiate, but there is separate stains for fibronectin. But in electron microscopy, typically they will be again having 10 to 15 nanometer fibrils. So which means you are seeing fibrils here predominantly. So that's what is happening here. But apart from that, if it's immunoglobulin derived, then you have multiple differential diagnoses for the same. So either it can be, fibrils, or it can be microtubules, or it can be this thing also, granular deposits also. So first I can split into immunoglobulin derived, means I can split into easily fibril derived. So in electron microscopy, I can see fibrils. Or in electron microscopy, I can see the microtubules. I can write as empty. Or I can see granular deposits in electron microscopy with monoclonal immunoglobulin. Monoclonal immunoglobulin deposits. Granular deposits with monoclonal immunoglobulins. Clear? So if it's fibrils, usually in exam, there will be only one thing here. Non-immunoglobulin, fibril, only one. That is called a fibrillary glomerulonephritis. Usually they'll come with a nephritic presentation, which I'll discuss in some time. Fibrillary glomerulonephritis. Fibrillary glomerulonephritis. Which typically a microtubule. Usually fibrillary glomerulonephritis will be having 7 to 15 nanometer fibrils in electron microscopy, and they'll be randomly arranged. There will be no particular arrangement. They'll be randomly arranged, 7 to 15 nanometer white fibrils. I think it will be 13 to 15, 15 to 30. It's not 7 to 15. 8 to 15 goes towards amyloidosis, isn't it? Usually they'll go towards amyloidosis. Arshin is asking, banded collagen seen in no, banded collagen is not seen in immunofluorescence. Banded collagen is basically seen in light microscopy. I just told you as an example, not immunofluorescence. So 8 to 15 is actually amyloid, but here you will see 15 to 30, correct. Double of that, that's how you remember. So 15 to 30 nanometer random fibrils will be typically a fibrillary glomerulonephritis. And apart from that, you have some microtubules also. Microtubules are of two types. Suppose if it's 25 to 30 nanometer parallel fibers, then you can talk about immunotactoid, which is very important. Immunotactoid glomerulonephritis. Or if it is arranged in the form of 25 to 35 nanometer, but short and paired type of microtubules, usually that goes towards a cryoglobulinemia. Cryo. Fine. Now, as far as the granular deposits are concerned, granular with the monoclonal immunoglobulin, there is a disease called MIDD. That's called a monoclonal immunoglobulin deposition disease. Monoclonal immunoglobulin deposition disease. Remember, most of them can be diagnosed very easily. There will be some clue for you. For example, for amyloidosis, you have congruent as a clue. For collagenofibrotic, you have banded collagen as a clue. For diabetic sclerosis, you have diabetes as the clue. For fibronectin congenital, autosomal dominant disorder, that is a big clue. And at the same time, for cryo, you will have cryoglobulins that will be positive, that is the clue. For monoclonals, some kappa lambda chain will be positive. Usually MIDD means kappa or lambda chain will be positive. So that will be a clue. I mean, sometimes they might be negative, but that will be a big clue here. So something will be the clue, but usually what are the things that you will not be able to differentiate very commonly in reality is your these three things, that immunotactoid type of glomerulonephritis and this fibrillary glomerulonephritis. These are two things that are very difficult to diagnose in reality, but there are many different cases where you can see immunotactoid and fibrillary glomerulonephritis. But nevertheless, there are three things which you need to differentiate. One is the AL type of amyloidosis, and second is the fibrillary type of glomerulonephritis, and third one is the immunotactoid type of glomerulonephritis. I have seen only 2 cases till now of fibrillary immunotactoid glomerulonephritis. Amyloidosis, many cases I have seen, but immunotactoid and fibrillary, only 2 cases till now. It's very, very rare. but still it can be associated with certain areas. So let us start with the congruent stain. We know as far as the congruent stain is concerned, positive, negative, negative, we know that very simply. So the composition, as far as the composition is concerned, we know these are fibrils. These are also fibrils, but here it's microtubules. Immunotactoid, it is basically microtubules, which I've told you already. And as far as organization is concerned, random organization, that's why I told you that. So here it will be a parallel organization, short paired empty microtubule. So parallel organization. So short paired is cryo. So we have parallel organization here. And as far as immunoglobulin deposits is concerned, it will be a monoclonal immunoglobulin deposition. It can be kappa, lambda, any monoclonal immunoglobulin will be deposited. Typically, it will be polyclonal. Once again, immunotactoid, sometimes it can be monoclonal as far as the immunoglobulin deposition is concerned. And what will be the light microscopy in histology? In light microscopy, there will be a deposits spreading through the mesangium. That's how they present, deposits throughout the mesangium. That's how you will see. Whereas in fibrillary type of glomerulonephritis, you might be seeing MPGN type, which is very classic, or they can come with an RPGN picture, RPRF and RPGN picture, or you can come with a chronic glomerulonephritis picture, which is also possible. For your immunotactoid type, very commonly, once again, they'll come with the MPGN type of a picture in light microscopy, or they can come with the atypical type of membranous nephropathy also. So which means you can remember MPGN and MN can have a immunotactoid can come with a MPGN or a MN type of picture in light microscopy. So as far as the clinical presentation is concerned, typically your amyloidosis, we know it's going to present like a nephrotic picture. They're coming with a nephrotic syndrome, and plus or minus they will be having a systemic disease very commonly. So we know amyloidosis itself is a systemic disease. Whereas immunotactoid and fibrillary, they'll present with a mixed nephrotic and nephrotic. Mixed nephrotic and nephrotic picture. Which means they'll be having glomerular hematuria. They can come with an RPGN. They can come with like gross hematuria also. Doesn't matter. So they'll use, and they will have a massive proteinuria also sometimes. So they can come with a mixed nephrotic and nephrotic picture most of the times, clinically speaking. But remember, hematuria is extremely common in immunotactoid, especially the glomerular type of hematuria is extremely common in immunotactoid type and fibrillary type of glomerulonephritis. And if you talk about the extrarenal manifestations, I told you systemic disease is very common, but pulmonary hemorrhage commonly happens with fibrillary type of glomerulonephritis, whereas you can get leukemias. Very commonly, it can happen in leukemias and lymphomas. Leukemias and lymphomas. Very commonly, that will be associated with your immunotactoid type of glomerulonephritis. Even though it may not be there, doesn't matter. Association with hematological disorders, hematological problems, very commonly, yes. We know AL type of amyloid is very commonly associated with multiple myeloma. Usually it's very rare with fibrillary glomerulonephritis. It's usually idiopathic in nature. And again, it can be seen. Yes, commonly seen. Like for example, CLL, non-Hodgkin, other types of non-Hodgkin lymphoma. And sometimes even with MGUS, monoclonal gammopathy of unknown significance. Currently, we don't call it as MGUS. MGUS, if it's having renal involvement, it's not MGUS, because MGUS, if it's only not producing any symptoms, that's called unknown significance. If MGUS like picture is having renal involvement, that's actually called as MGRS. That's called a monoclonal gammopathy with renal significance. It should not be called as MGUS anymore. So only if you don't know the significance of that monoclonal gammopathy, then we call it as MGUS. If you clearly have renal involvement, then it will be called as monoclonal gammopathy of renal significance. So that's different. What will be the treatment? Treatment, typically I'm going to use a steroid. There's no doubt about that. Steroid, because most of the time it will be associated with multiple myeloma. Multiple myeloma. So steroid, typically I'll be using a dexamethasone plus same treatment as of multiple myeloma. Like I'm going to use bortezomib or carfilzomib, which is a proteasome inhibitor, plus I'm going to use a lenalidomide or a pomalidomide. This is the immunomodulator. This is a standard therapy for multiple myeloma. Same thing I can use for AL type of amyloidosis. Usually here I'll be using a steroid plus at the same time cyclophosphamide. So this is the usual treatment here. Here, because most of the time it will be due to secondary cause, it is treatment of the underlying disorder. Treatment of underlying disorder. So that's what is going to happen here. This is what I'm going to use here. Clear? So these are the three important differential diagnoses for glomerular disorders with organized deposits. When you suspect organized deposits, like microscopy in a simple HND staining, if you see this mesangial hypercellularity with mesangial expansion with extracellular matrix deposition in the mesangium, you think about organized deposits. In that, two things that is very commonly important for exams at the same time, which can present with a mixed nephritic and nephrotic, but most often they'll come with nephritic kind of presentation is fibrillary and immunotactoid type of glomerulonephritis. So these two things you need to know. So how to differentiate and how will you really find out in reality. So most of the time that nature of the fibrils is very important and microtubules very important. If you see a nephritic kind of presentation, the final nutshell is these two things only. Because in AIIMS and INACET, you don't call AIIMS now. INACET, they might ask if AIIMS is preparing. So if you see more of a 25 to, I wrote 30, since it's 90 basically. 25 to 90 nanometer. But the most important clue is the parallel fibers. If you see parallel microtubules, if you see, then you can go for immunotactoid. So this will be the biggest clue in exam. 25 to 90 nanometer parallel fibrils, go for immunotactoid. If you see 15 to 30 nanometer random fibrils, then think about a fibrillary glomerulonephritis. Remember, microtubules, parallel arrangement, immunotactoid, fibrils, random arrangement, 15 to 30 nanometer, it is fibrillary glomerulonephritis. So this is a completely new set that you need to know. That is glomerular disorders, organized deposits. In that, the most important, as far as I know, is fibrillary and the immunotactoid. So please don't forget that, at least, because that's something that is quite becoming common nowadays, especially in patients with who previously we categorized as idiopathic glomerulonephritis. Now there are new varieties that are coming up. That is fibrillary and immunotactoid type of glomerulonephritis. I think that settles the debate of glomerular disorders. I think we have discussed a whole lot on glomerular disorders, completely on glomerular disorders. I don't think you need anything more than this as far as the glomerular disorders are concerned. Don't worry, in exams, the questions usually will be much, much simple than what you predict. It's just about the key points that you need to know. That's all, nothing else. So I think you can understand the glomerular disorders in a very nice way and a detailed way. And this is more than enough for your exams, and even for practice itself, this is more than enough. With this, I'll stop the session because I need to go for something else. And we'll see tomorrow. Tomorrow morning, I'll try to start by 11 because today morning we had so much of problem. Their work is going on in another area and I cannot move from home also. And there are so much things that have happened in today. So, and usually it happens. My days always will be eventful because of a lot of things that are going on around me. But nevertheless, tomorrow I'll try to start by 11:30 for sure. So come, you can join me tomorrow by 11:30. So with this, I'll close down the session. Tomorrow we'll be continuing with the nephrology. Clear? Thank you. Good night. Yeah, of course, I'll intimate before the class. Don't worry about that. I'll intimate before the class. Thank you. Bye-bye.